Welcome to Beyond Pain, Part 1, Introduction to Pain. My name is Dr. April Gamble. I'm an American physiotherapist with a doctorate of physical therapy. I am also a certified lymphedema therapist. I am currently the secretary of the Global Health Special Interest Group of the American Physical Therapy Association. I am also the chair of the Global Outreach Committee of the Oncology Rehabilitation Group of the Michigan Physical Therapy Association. I am also the founder and CEO of ACR, the American Center for Rehabilitation, which is based in the Kurdistan region of Iraq. I have lived in the Middle East region for over 5 years, and I work to come alongside communities to work in solidarity with them to strengthen rehabilitation services for historically marginalized and underserved populations. I'm happy to bring to you today Beyond Pain. It is an evidence-based and multilingual pain science training and treatment curriculum. It is designed to support healthcare professionals, especially physiotherapists, working in the Middle East and North Africa region, to deliver biopsychosocial care to persons with persistent pain. It's designed with an emphasis to meet the needs of survivors of psychological trauma, including war, torture, and displacement. Beyond Pain was developed as a component of the IASP Developing Countries Project. It has been supported by numerous organizations. Additionally, various experts have contributed to the content of this manual. You can see the experts and organizations listed here. I myself am the primary author. A significant contributor of this manual was Anna Mette-Kar. She is a physiotherapist and international rehabilitation trainer at Dignity, the Danish Institute Against Torture. This is part 1 of an extensive training curriculum on modern pain science. In the last decade, significant changes have happened in how healthcare professionals understand, treat, and assess pain. This curriculum aims to provide you with the current evidence in this field so that you can better treat persons with pain. Part 1 will describe the theories that have been used in the past to understand pain. It will also introduce you to new evidence-based theories that we should now be using. After completing Part 1, you should be able to do the following. 1. Understand how theories affect how you, as a healthcare professional, assess and treat pain. 2. Describe the biomedical theory and how it is not accurate. 3. Describe the evidence-based theories that we should now use. 4. Describe the evidence-based definition of pain. And 5. Demonstrate the ability to use the ICF model to organize information about pain. First, it is important to recognize that the content of Beyond Pain is not my beliefs as the primary author. Rather, it includes current research evidence and best practice recommendations as of 2020. Evidence-based practice is the responsibility of all healthcare professionals, including physiotherapists. Evidence-based practice is also termed EBP for short. EBP is an approach where healthcare professionals use research evidence, their clinical experience, and the patient's needs to make clinical decisions about the most appropriate and effective treatment plan. Beyond Pain attempts to provide you with the most current research evidence so that you can combine this with your clinical experience as well as the patient's expectations and preferences to provide the most effective treatment. We want to acknowledge that the information in this Beyond Pain curriculum may be very different from what you have learned in the past. When you learn this new information, it may feel like it is in conflict with previous information you have learned. This can feel uncomfortable and even threatening. You can think of it like the picture here of the two bulls fighting. The old information and the new information can feel like they're fighting each other. For example, in Part 1, we will discuss the biomedical theory. Most likely, you are mainly using the biomedical theory to treat patients. Most healthcare professional educational programs teach their students the biomedical theory. However, based on recent research, the biomedical theory is no longer accurate for treating pain. This curriculum will be based on the new evidence-based theories. Part 1 will even inform you that the biomedical theory should not be used at all. As you're learning all this new information, you may feel anxious or resistant to learning and applying this information into your work with patients. This is very normal. But if you take the time and effort to understand the new information and apply it in your work with patients, you will find that the new information can be integrated into what you already know and what you already do. We're not asking you to throw out information that you already know or all your clinical experience, but rather we will help you combine the new information with it. You can think of this as working to get the two bowls to be calm and working alongside each other. In part 1, we're going to discuss theories of pain. A theory is defined as a system of ideas that explain something. We all have theories that influences what we do and how we work with patients. For example, if you have a theory about how posture can affect someone's pain and how specific exercises will help for a specific problem, then that will influence how you work with a patient. Our theories have a significant effect on how we assess and treat pain. So we must make sure that we are using theories that are based in research and evidence. We will now describe the biomedical theory and the history of how this theory developed. Then we will describe why this theory is no longer accurate based on research. Lastly, we'll describe the current evidence-based theories, including neuroplasticity, the neurophysiology of pain, and the biopsychosocial model. We'll introduce these new theories in part 1, and then you will learn how to use these theories as you complete the rest of Beyond Pain. We will start by defining the biomedical theory. This is also called the biomedical model. As this curriculum is discussing pain, we will focus on how the biomedical theory and other theories describe pain. However, healthcare professionals use these theories to explain disease and injury as well. The biomedical theory describes that pain is a direct result of biological factors such as tissue injury or a pathology in the tissues. When we use the term tissue, we are referring to any structure in the body, including joints, ligaments, muscles, tendons, organs, etc. The biomedical theory explains pain like this. Tissue injury equals pain. Tissue injury causes pain. Tissue injury is the only factor that causes pain. The biomedical model describes that if you treat the tissue injury and the tissue pathology, then the symptoms will decrease and function will improve. Research and clinical practice have shown that pain and disease are much more complex than this biomedical theory describes. The biomedical theory is not an effective theory to use when treating pain. In this curriculum, you will learn the complexity of the pain experience. Let's look at an example. You will see how using a biomedical theory affects how the healthcare professional assesses and treats pain. It may not be clear to you yet why this approach is not accurate. The goal of sharing this example now is to demonstrate how our theories affect how we treat a patient. Soon, we will show you the same example, but with a new and accurate theories. Example is, you have a 50-year-old male patient with bilateral knee pain. He tells you that his doctor said that he has osteoarthritis in both knees, and that's why he has pain. You do an assessment and you conclude that the osteoarthritis is the cause of pain. So, your treatment then includes 1, educating the patient that osteoarthritis is a chronic condition, so he's going to always deal with knee pain. 2, educating the patient that he can manage his pain by avoiding certain activities in his daily life. 3, using ultrasound to help with pain relief. And 4, teaching the patient range of motion and strengthening exercises to help with pain relief. In this example, the healthcare professional is applying the biomedical theory. This theory makes the healthcare professional conclude that patient's pain is a direct result of osteoarthritis, a type of tissue injury. Also, the treatment plan is using the biomedical theory. This is clear because the healthcare professional is focusing on a few things. 1, they focus on managing pain and not treating the pain or making the person living pain-free. 2, educating the patient that the pain will be permanent. And 3, teaching the patient that some activities in daily life should be avoided as they are harmful and cause pain. This is how you can tell that they are applying the biomedical theory in the treatment plan. This example may sound very logical and similar to your work with patients, especially if you're currently using the biomedical theory. The biomedical theory has traditionally been taught in educational programs for healthcare professionals like surgeons, doctors, nurses, and physiotherapists. Only recently have healthcare professionals as well as healthcare educational programs stopped teaching this biomedical theory and have started teaching the newest theories. Research and clinical practice have shown that pain and disease are much more complex than the biomedical theory describes. Also, research has shown that a biomedical theory does not result in long-term improvements in a person's ability to function and live their life to the fullest. The biomedical theory is not an effective theory to base our clinical treatment of pain on. In this curriculum, we're now going to teach you how to learn the new theories. We will soon return to this case example so that you can see how the biomedical theory is not as sufficient for this specific patient and many of the ones that you work with. We will now look at how the biomedical theory was developed and how research has developed the current theories of pain. The biomedical theory of pain was started by Descartes' explanation of pain in the 17th century. He described pain as a process that only occurred in the sensory nervous system. It was believed that the pain was experienced in the sensory system at the location of the injury, and then this pain message was sent directly to the brain. See the classic picture representing this theory here on the screen. In the picture, there is a fire on the foot that causes a tissue injury, and these pain signals are then sent up to the brain. With this initial theory of pain, there was no understanding that psychological, social, and other factors could contribute to the pain experience. Pain was understood as purely a result of the stimulus to a sensory nervous system. This 17th century theory is the basis of the biomedical theory, as it describes that all disease and illness, including pain, is resulting from only biological processes. This understanding of pain was maintained into the 1900s. In 1894, a researcher described that there were different types of sensory receptors in the sensory nervous system. He described that there were unique sensory receptors for each type of stimulus, including touch, temperature, pressure, and pain. This was integrated into the biomedical theory at that time by saying that pain receptors sent pain signals to the brain. You will soon learn that the research has shown that this is not true. There are no pain receptors and there are no pain signals that get sent to the brain. Now we will discuss the gate control theory of pain. In the 1960s, a new theory of pain was described by the researcher named Melzack. The new theory was called the gate control theory of pain. You may know this theory that is still very commonly taught. The gate control theory of pain was the first theory that acknowledged that psychological and social factors contribute to pain. The basic idea of the gate control theory is that there is a gate in the spinal cord that controls the pain messages sent to the brain. The brain can control the gate to increase or decrease those pain messages that the brain receives. The theory describes that negative emotional states like anger and hopelessness would open the gate, which would increase the pain experience. The gate can also be closed by factors that decrease stress, like positive social relationships and healthy habits. If the gate closes, the pain experience decreases. The gate control theory of pain was the first theory that recognized the mind-body connection and the interaction between biological, psychological, and social factors. However, current research shows that this theory does not completely and fully and accurately describe the way that pain is experienced, because we now know that there are not pain messages that are sent to the spinal cord and the brain. As we discussed, the theories that we believe affect how we treat persons with pain. The biomedical theory has key ideas about pain that are wrong. So it's important to know that if we apply these ideas, the treatment of pain that we do with persons with pain will not be as effective. The key ideas that are based in the biomedical theory and that are wrong include 1, a person feels pain when pain signals are sent from the body to the spinal cord and to the brain. 2, there's a pain center in the brain. And 3, there are pain receptors in the body. Before moving on, I'd like to ask you to do an independent learning activity at home. This will help you integrate this new information into your clinical practice. So what I'd like you to do is think of a client or a patient that you've worked with where the biomedical theory does not fully explain or help you understand that person's condition and how they're presenting to you. So let me give you an example. of a client that I worked with recently. He was a 50-year-old man with maybe 3 years of back pain, and it comes and goes, and he was in an episode of severe back pain now. He also reported that he has headaches frequently, difficulty controlling anger, sleep problems, and he also gets other pains throughout his body, sometimes his knee, sometimes his shoulder, sometimes his neck, and it moves around. He has not had any surgery. However, many doctors have told him that he should have back surgery because he has a disc prolapse at L5-S1. During the physiotherapy assessment, I asked to do lumbar active range of motion, including flexion, extension, and rotation. During lumbar flexion, I asked him to bend forward, reach for his toes, and he did about 20 degrees of lumbar flexion, and then he said, no, it hurts too much, it's too bad, I'm not able to do that. So then I finished the assessment. At the end of the session, he then is about to leave, so he bends forward to get his shoes. As he does this, he goes into pretty much full lumbar flexion, and he puts his shoes on, he stays there for a minute or so, ties up his shoes. And so this is an inconsistent pattern where when I asked him to do lumbar flexion in the exam, he did about 20 degrees, but then when he was putting on his shoes, he bent forward fully and didn't express any pain or problems with that. So this inconsistency cannot be explained by the biomedical theory. And it should not be understood that he's exaggerating or he's lying. He actually experienced 2 different amounts of pain during that. He had more pain during the lumbar flexion in the assessment and not a lot of pain during the lumbar flexion when putting his shoes on. The biomedical theory can't explain that, right? Because tissue injury equals pain under the biomedical theory. So therefore, his tissue injury didn't change in those 20 minutes between those 2 activities. So he should have experienced the same amount of pain during the lumbar flexion, the assessment, and the lumbar flexion in the putting the shoes on, but he didn't. So the biomedical theory doesn't help me understand what's going on here. As we will see, the biopsychosocial theory and the neurophysiology of pain will help us understand why we see these consistencies. So now, that's just one example. There might be many, many examples that you think of where the biomedical theory just doesn't help you understand the person's experience of pain and how they present to you during an assessment and during treatment. So what I'd like you to do is now pause the video and take some time to reflect on the clients that you work with and think of a specific example where the biomedical theory just doesn't help you understand or explain that patient's condition and doesn't help you understand enough to treat that person. Take some time to think about that, write it down, and when you feel like you finished that activity, you can start the video again. There are 3 evidence-based theories that are based on current research. We must understand these so that we can effectively treat persons with pain. The theories are neuroplasticity, neurophysiology of pain, and the biopsychosocial model. We will describe neuroplasticity in detail here in part 1 of Beyond Pain. We will introduce the concepts of neurophysiology of pain and biopsychosocial in part 1 and go into more detail in part 2 of Beyond Pain. Neuroplasticity is the first theory we're going to describe now. It is defined as the nervous system's ability to change its structure and its function. The structure and function of the nervous system is not fixed. It changes throughout our entire lives. This process is what allows us to learn new movements, new skills, and new information. Neuroplasticity is what allows us to think new thoughts and change our behavior. It is what allows us to recover from disease or injuries. To understand neuroplasticity, we must recall the anatomy and physiology of the nervous system. The nervous system is made up of neurons. Neurons transmit and receive electrical signals. Neurons have 3 parts: dendrites, the axon, and the cell body. Signals are received through the dendrites. Signals are sent through an action potential, and it travels down the cell body, through the axon, and to the axon terminals. The signal then reaches the synapse, which is the space between one neuron and another neuron. The synapse is a point between 2 neurons where signals are transferred from one neuron to the other. A single neuron is not able to do anything by itself. A neuron can only work when connected to other neurons. Neural pathways are the tracks that connect one part of the nervous system with another part of the nervous system. The nervous system is made up of neural pathways in the brain, spinal cord, and peripheral nervous system. Neural pathways can be very simple and include only a few neurons to very complex and include hundreds of neurons. We will now watch a video. This video is available publicly on YouTube. This video will help you learn a little bit more about neuroplasticity.
Not so long ago, many scientists believed that the brain did not change after childhood, that it was hardwired and fixed by the time we became adults. But recent advances in only the last decade now tell us that this is simply not true. The brain can and does change throughout our lives. It is adaptable, like plastic. Hence, neuroscientists call this neuroplasticity. How does neuroplasticity work? If you think of your brain as a dynamic, connected power grid, there are billions of pathways or roads lighting up every time you think, feel, or do something. Some of these roads are well-travelled. These are our habits, our established ways of thinking, feeling, and doing. Every time we think in a certain way, practice a particular task, or feel a specific emotion, we strengthen this road. It becomes easier for our brains to travel this pathway. Say we think about something differently, learn a new task, or choose a different emotion. We start carving out a new road. If we keep travelling that road, our brains begin to use this pathway more, and this new way of thinking, feeling, or doing becomes second nature. The old pathway gets used less and weakens. This process of rewiring your brain by forming new connections and weakening old ones is neuroplasticity in action. The good news is that we all have the ability to learn and change by rewiring our brains. If you have ever changed a bad habit or thought about something differently, you have carved a new pathway in your brain and experienced neuroplasticity firsthand. With repeated and directed attention towards your desired change, you can rewire your brain.
You can think of the nervous system as a series of walking trails in a village in the mountains, like the picture here. The trails run all through the village to connect a house to each other, or connect the houses to the market or to the mosque, and also connect the village to the mountains via goat trails. The trails are like neural pathways in the brain. Each neural pathway has a specific purpose, just like each trail in a village has a specific purpose. We can use this analogy to better understand neuroplasticity. As people use a walking trail more often, the grasses and dirt gets pushed down, and the trail becomes easier to walk on. This is the same for a neural pathway. As you repeat an action, a thought, or an emotion, that specific neural pathway gets stronger and more efficient and easier to use. If people stop using a trail in the village, it gradually becomes more difficult to walk on because the grass grows over it, the dirt piles up, and it becomes more difficult. This is the same for a neural pathway. If you stop using a neural pathway, like you stop doing a certain skill or a certain movement or thinking some certain thoughts, that neural pathway becomes weaker and more difficult to use. If a new house is built in a village, then they would create a new walking trail, connecting that house to the others, to the market, and to the mosques, and the other places that people from that house need to go. At first, to create these trails, it takes a lot of effort. You have to dig out the dirt, pull out the grasses, and walk on it a lot until it gets easier to use. This is the same in the nervous system. If you learn something new or have a new experience, a new neural pathway is created. As you practice the new skill or do the new experience more often, and you keep using the neural pathway, it will become stronger, more efficient, and easier to use. As you walk through the village, you naturally use the trails that are easier to walk on. The nervous system is the same. The nervous system will naturally use the neural pathways that are strong and more efficient, and that they have used a lot in the past. It takes more effort for the nervous system to use a neural pathway that's new or that hasn't been used very often. So the key idea is that neuroplasticity is the process by which these trails or neural pathways form and become stronger and more efficient, or weaker and less efficient, based on how often they are used. We're now going to watch another video. This video is also publicly available on YouTube, and it will help us even further understand the various changes in the nervous system that can happen due to the effect of neuroplasticity.
Neuroplasticity is the ability of the brain to change or rewire throughout a person's life. It is the basis of learning and brain repair after injuries. The brain consists of billions of neurons. Neurons communicate with each other through a space between them called a synapse. This communication is made possible by chemical messages, or neurotransmitters. Basically, the presynaptic neuron releases a neurotransmitter which binds to and activates a receptor on the postsynaptic neuron. A typical neuron can have thousands of synapses or connections with other neurons. Together, they form extremely complex networks that are responsible for all brain's functions. Synaptic connections, as well as neurons themselves, can change over time, and this phenomenon is called neuroplasticity. Neuroplasticity is activity-driven and follows the use it or lose it rule. Frequently used synapses are strengthened, while rarely used connections are weakened or eliminated. New activities generate new connections. Changes in synaptic strength can be temporary or long-lasting depending on the intensity and reoccurrence of the signal the synapse receives. Neurons can temporarily enhance their connections by releasing more neurotransmitter, activating a new receptor, or modifying an existing receptor. This is the basis of short-term memory. Long-term memory retention requires strong or sustained activities that produce structural changes, such as growth of new dendritic spines and synaptic connections, or even formation of new neurons. Structural neuroplasticity may also result in enlargement of the cortical area associated with the increased activity, and shrinkage of areas that receive less or no activity. For example, in right-handed people, the hand motor region on the left side of the brain, which controls the right hand, is larger than the other side. Neuroplastic changes can also be functional, meaning neurons may adopt a new function when they are sufficiently stimulated. This is how the brain survives injuries, such as strokes. Healthy brain tissues can take over the functions of the damaged area during post-stroke rehabilitation. Some stimuli, such as stress or physical exercise, can cause certain neurons to switch from one neurotransmitter to another, often converting them from excitatory to inhibitory or vice versa. This neurotransmitter switching is thought to be the basis of behavioral changes induced by such stimuli. An intriguing example of neuroplasticity is the phenomenon of phantom limb sensation, in which patients who have lost a limb through amputation can still feel the limb. For example, patients may feel that their lost arm is being touched when their face is touched. Because incoming sensory signals from the arms and face project to neighboring regions in the somatosensory cortex, it is plausible that sensory inputs from the face spill over to the now inactive arm region that no longer receives any inputs, tricking the brain's higher centers into interpreting that the sensation comes from the absent arm. The plasticity of the brain is not limited by age, but is much more remarkable in children as their young brain is still developing. Neuroplasticity is essential for normal brain development. It helps create functional brain circuits and is the basis of learning. This is why acquiring a new skill, such as speaking a language or playing a musical instrument, is much easier in childhood than in adulthood. But changes brought about by neural plasticity can also be negative, maladaptive, and have unfortunate consequences, especially if they happen in childhood. Childhood traumas are more likely to have long-lasting effects into a person's life. Neuroplastic changes happen all the time, but their magnitude depends on the amount of activity the brain receives. More practice leads to more learning. Keeping the brain busy is the way to keep it healthy and effective. Thank you for watching. If you like our videos, be sure to check out our new Patreon page. Patreon is a simple way for you to contribute to our production and get great rewards in return. Join us to make videos like these happen.
A key point to understand is that neuroplasticity is occurring at all ages and not just when we are young. Research has shown that changes happen more easily and at a greater rate when we are young. However, at all ages, our nervous system can change in response to what we do. We will look now at actually what happens in the nervous system when it changes. Changes can happen at many levels of the nervous system and can happen in the brain, spinal cord, and peripheral nervous system. This is a very complex process, and it's not possible to go into comprehensive detail of this within Beyond Pain. The key point to understand is that the nervous system changes in many different ways and in many different locations. Here is a general summary that occurs in the nervous system. As you can see on the list on the slide, changes occur in the brain, the spinal cord, and the peripheral nervous system. Within the Beyond Pain manual and within the text, you will find some more details about the various changes that happen at the levels of the nervous system. These various changes occur in our nervous system in response to what the nervous system is exposed to and our experiences. Experiences can be thoughts, emotions, performing an action, learning something new, forming a memory, recalling a memory, or even injury and disease. Experiences that change the nervous system also include injuries like a CVA or a traumatic brain injury, and diseases like peripheral neuropathy or cancer. And as you will learn in part 2 of Beyond Pain, pain is also a pathological state that may cause changes in the nervous system. As a healthcare professional, we work to improve the function of patients. Whether you knew it or not, you have been using the theory of neuroplasticity to achieve improvements with your patients. For example, after a person has a CVA or a stroke, neuroplasticity is the reason they can regain the ability to walk. If neuroplasticity did not occur, then we would never see patients improve after a CVA. Neuroplasticity is also the reason why having rehabilitation is important after an injury or when a person has a disease or illness. Rehabilitation gives the nervous system opportunities to experience new things and to practice skills which cause the nervous system to change. Neuroplasticity is the theory that underlies how we treat pain. We are going to talk in detail about in part 2 of Beyond Pain about the changes that happen in the nervous system when a person experiences pain. We will also discuss the changes that happen as a result of the treatment of pain. We know that these changes happen and they occur because of neuroplasticity. The key message is that the nervous system changes based on what it experiences, and we as healthcare professionals and physiotherapists can influence the nervous system to function better. The neurophysiology of pain is the next evidence-based theory that we're going to discuss. The neurophysiology of pain is defined as how the nervous system works when someone experiences pain. Part 2 of Beyond Pain covers this in a lot more detail, but we're going to introduce it now. But now that the neurophysiology of pain is one of the main 3 theories, you must understand it so that you can treat pain effectively. So now we will watch a video discussing the neurophysiology of pain so you can start to be introduced to this complex topic.
Let's say that the outline of this drawing represents a person. Over here, we are going to list things we call body or tissue information. Body information is probably the kind of information you're the most familiar with. If you've had any healthcare before, I'm sure you've heard about muscles, bones, joints, tendons, ligaments, fascia, skin, spinal discs, any of those things, as well as possibly even, or maybe you haven't, blood vessels, your organs, and chemistry. Chemistry is an interesting one. Some of the chemicals you may have heard of include immune chemicals, such as the ones which fight infection and help healing. Commonly, these are seen as inflammation. Chemistry also includes your endocrine system, which is a fancy word for a system that regulates hormones and stress chemicals such as adrenaline or cortisol. Now here's the interesting thing. Our person does not know anything about our body without another tissue. These tissues are the nerves, more specifically the nervous system. Our individual nerves, of which there are 400 unique nerves, 45 miles of continuous wire, each of those nerves have specialized sensors which tell you about your tissues. They tell you about your chemistry. They tell you about your blood flow. They tell you about movement. They tell you about temperature. And now we even believe that it's possible because of these fine little temperature sensors that we may be able to even detect other subtle changes in weather. So what happens next? Our nerves create messages. They create nerve impulses which become inputs into our person. Specifically, they have to travel up to our brain, where our brain has to make decisions about this information. Our brain doesn't stop here. It has to process other information, and this includes information about our environment. Our environment includes very physical properties. Physical things are like where we are physically in space. If you've ever had any issues with blood pressure, you'll notice that if you measure your blood pressure at home, it may be lower than it is at the doctor's office. There are many physical properties in the environment that account for that. Our overall mood is a very important environmental factor. It influences many things. Also our emotions such as stress, anxiety, uncertainty, fear, anger, joy, peace. All of these things are chemistry. They are electricity. They are information and impulses that must be transmitted to our brain, just like the information from our body, that must be reviewed and analyzed, and decisions have to be made in the brain about this information. Sleep is a major environmental factor. One of the most well-researched influences on pain, on difficulty with doing day-to-day activities, have to do with sleep. If we can help you with sleep, you will be healthier. You will have less pain. We also know that the social environment is very important. These include things about our personal life, family, friends, but also our work. We spend a lot of time in work. The best example of this is, if you stub your toe, normally it would hurt. But if you're around people that you would be embarrassed or it would be best you don't express your pain, you're going to hurt less. There are countless other examples of how the people around us and the work that we're in and what we do and how we are socially engaged can influence our pain, our function, our ability to do life. And here again, environmental information becomes an input which the brain must analyze, must review, and it has to review these in 9 different areas. These 9 areas work together to make decisions about what to do with the information that's coming into our body. Over time, these 9 areas can also develop scripts or programs which can become memories, and these memories include protection memories. Protection memories look at previous injury, previous pain, which we need to separate out because, as you'll learn, pain and injury are not totally related. They can be, but they don't have to be. But it also looks at your thoughts and beliefs. What do I know about this pain or injury? What have I done that's helped, that doesn't help? And what have others done that seems to have helped and didn't help? And here's another amazing thing. These protection memories now become chemistry. They become electricity. They become nerve impulses. And now they become inputs back into the brain, which now has to be reviewed every time that information comes into our body. Now the brain has to make decisions. And when it makes these decisions, these result in outputs. These outputs include pain. Yes, it really took this long for us to be able to experience pain. All these things must be decided upon in an instant, whether you stub your toe, step on a nail, burn yourself. All of these decisions about our body, about our environment, and even our protection memories have to be decided upon in order for us to be able to create a painful experience. Other outputs of our brain as a result of this decision making includes movement changes. Most common, what we think about with movement, we think about strength, endurance, muscle coordination, muscle balance. But the things you might not realize is that our muscle or even our fascial tension, if you're more familiar with that, and even entities such as trigger points, which you may have heard of, are actually outputs of the body as strategies for protection. Stiffness is another movement change. This includes that morning feeling like you're 900 years old, getting out of bed stiff feeling, but also simple things like certain areas, certain joints that can feel stiff, and even a healthcare provider who says that joint's a little stiff. Some of what they're feeling is in fact really the result of decisions of your brain. One of the coolest outputs currently being researched is this idea of altered physiology, which is that the brain's outputs as a result of its decisions include changes in our immune system, include changes in our endocrine or endocrine system. The brain can decide how much inflammation to send to a region of the body or the whole body. We know that there are some inflammatory changes in even diseases like rheumatoid arthritis, where now we've been able to add electrical impulses to a specialized nerve from the brain called your vagus nerve, and we can dramatically change how much inflammation the whole body is experiencing. Now, because movement changes, this means that suddenly what became an output now can be an input. How we move changes, and now our body information has changed as a result of this different movement. Our altered physiology means that our chemistry sensors in our body must be picking up new chemical trails from what the brain had decided was a good protection strategy. And finally, of course, all of these changes means that all of a sudden our pain experience, which by the way cannot be an input into your body, can, however, influence your environment, how you feel about things, your mood, your sleep. If you hurt, it's hard for you to sleep. All these things are now all of a sudden coming full circle, creating this loop, and you can see how pain can become chronic. You can also see how all pain is complicated. It's never simple. It's never just a light switch. But the great news is, as we're learning all these things, we are now learning how much we can do to improve it. Your pain can improve. You can do more. You can live a better life. Follow this series of videos, as well as follow along with your clinical provider who specializes in pain treatment to get more information on how you can treat your pain.
The last theory that is important to understand is the biopsychosocial theory. The biopsychosocial theory describes that pain results from an interaction of biological, psychological, and social factors that are unique to each person. The biomedical theory states that pain is caused by a tissue injury, but the biopsychosocial theory states that pain results from a variety of factors from all three of these areas. Biological factors are events in the body that activate sensors in our body. The biopsychosocial model describes input from the body, like tissue damage, muscle tension, or inflammation, may contribute to pain in the form of biological factors. Psychological factors are our emotions, but also the things we think, say, believe, and predict. Social factors are any interactions that a person has with other people and the roles and responsibilities that they have in their daily life. The biopsychosocial theory states that pain is a result of the interaction of a variety of factors from all three of these areas. Let's look at another example of a human experience, which involves the biological, psychological, and social factors. That is, eating a meal. The pleasure of eating a meal is influenced by biological, psychological, and social factors, just like the experience of pain. So biologically, there is the smell of the food, the visual experience of looking at the food, the sensation of the food in our mouth, and the flavor of the food on our taste receptors. All of that information is sent to our brain and influences our experience. Psychologically, there are the beliefs and expectations that we have about the food. For example, have you ever experienced eating a food that someone told you is the best in the city, and then it actually tastes better when you eat it? Socially, often our enjoyment of a meal is based on the social environment. Have you ever experienced where a meal tastes better when you're eating it with friends or family in a fun environment rather than eating the same food by yourself? A person's experience of eating a meal results from the interaction of biological, psychological, and social factors, just like a person's experience of pain. Eating a meal is a personal human experience that cannot be measured. Pain is also a personal human experience that cannot be measured. Pain is not like blood pressure or body temperature that can be measured by a simple tool. We cannot measure pain, but we can understand the pain experience by asking our patient about how they experience it. We can understand it by assessing the biological, psychological, and social factors contributing to a person's pain. If we understand the factors that are contributing to pain, then we can better help a person that is struggling with pain. Remember our example that helped us understand the biomedical theory? We will now look at the same example to see how applying the biopsychosocial theory affects how we as a healthcare professional treat the same patient. Remember that our client is a 50-year-old male with bilateral knee pain. He told you that his doctor says that he has osteoarthritis in both knees and that's why he has pain. When you do the physiotherapy assessment based on the biopsychosocial theory, you would conclude the following. 1. The biological factors contributing to this man's pain include decreased active range of motion of both knees, overall leg weakness in both legs, poor endurance of the leg muscles, and mild swelling and inflammation in both knee joints. The psychological factors contributing to this man's pain experience include that he believes the pain is permanent and that it will not get better. He is also afraid to move his knees because he thinks that that will make the pain worse and cause more damage in his knees. He also is avoiding daily activities like sitting and climbing stairs because of knee pain and the fear of having more knee pain. The social factors contributing to this man's pain experience is that he is worried about not being able to work because of the knee pain, and he also takes care of his elderly mother who has severe knee pain. If you're using the biopsychosocial theory, you treat this patient by doing the following. You educate them that the changes in the knee joint are normal changes that happen with age, the pain is not permanent, and the pain is not something to be afraid of. 2, you do range of motion, strengthening, and endurance exercises with this patient. 3, you teach the patient how to use ice and gentle range of motion exercises at home to reduce the swelling and inflammation in the knees. And 4, you teach the patient how to do daily activities so that he no longer avoids physical activity and movement of the knees. Review the treatment that we provided earlier for this patient based on the biomedical theory. I think you're going to see that when applying the biopsychosocial theory, the exact same patient is seen in a very different way. For example, when applying the biopsychosocial theory, the physiotherapist gathers information in the assessment that is more than just the biological factors. Also, when applying the biopsychosocial theory, the treatment plan involves treatment that addresses biological, psychological, and social factors. We have now discussed the 3 main theories we should use: neuroplasticity, neurophysiology of pain, and the biopsychosocial. Based on these evidence-based theories of pain, we can define pain. The International Association for the Study of Pain, or IASP, established the globally recognized definition of pain. You can see it here on the screen. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pain is no longer understood within the biomedical theory as a biological process that occurs due to tissue damage, but rather, as you can see in the new definition of pain, pain is a protective response that results in a sensory and emotional experience. Pain is experienced due to tissue damage or from what the brain perceives as a threat to tissues. This means that a person can experience pain even when the body does not have tissue damage. This will become clearer as we discuss more about the neurophysiology of pain in part 2 of Beyond Pain. In summary, the biomedical theory should no longer be used. Rather, we should be using the theories of neuroplasticity, neurophysiology of pain, and biopsychosocial. These theories significantly change how we understand, assess, and treat pain. Let's look at the table below to understand how we've shifted from the ideas based on the biomedical theory to the ideas based on the new theories. This information will become more clear in part 2 of Beyond Pain. You see in the table on the left, the biomedical theory described that a person feels pain when pain signals are sent from the body to the spinal cord to the brain. But the new theories and the new research has revealed that danger messages are sent from the body to the spinal cord to the brain, and pain is always an output of the brain when the brain decides that there is danger. Again, on the left side of the table, the biomedical theory described that there is a pain center in the brain. But rather, as you can see on the right side of the table, pain is an experience that involves many areas of the brain. And lastly, the biomedical theory described that there are pain receptors in the body, But we now know, based on research, that there are receptors in the body that can send danger messages, but there are no pain receptors. The last topic we are going to discuss in Part 1 of Beyond Pain is the International Classification of Functioning, Disability, and Health, also called the ICF model. The ICF model was developed by WHO, or the World Health Organization. It is a framework for describing health, function, and disability. The WHO developed the ICF model so that healthcare professionals all around the world would have one way to organize and communicate information about a patient. The ICF model is based on the biopsychosocial theory. It is a tool that we can use to apply the biopsychosocial theory in your work as a healthcare professional, and it also is a way to organize information to share it with other colleagues. We're going to learn about the ICF model now and continue to use it throughout the full Beyond Pain curriculum. Here is the ICF model. You can see that it has 4 boxes. The top box is called the health condition. Then you have a box labeled problems with body structure and function, also known as biological factors. Then the box labeled problems with activities and participation. And then the bottom box labeled personal and environmental factors. You can also think of this box as the psychological and social factors that contribute to a person's functioning. Let's look at this in a little more detail now. As I said, the ICF model is based on the biopsychosocial theory. So it helps you collect information about the biological, psychological, and social factors that are contributing to a person's condition and function. The ICF model does not focus on the health condition or medical diagnosis of a person, but rather it focuses on how a condition is affecting a person's ability to live their life fully and how it affects their ability to do things that are meaningful to them. The ICF model focuses on the interaction between all the different parts, including biological, psychological, and social factors. And it shows that if one factor is changed, that means other factors will be changed in turn. This is why on the model you see that there's arrows going both ways that connect all the different parts. The ICF model can be used by all healthcare professionals and with patients of all ages, all conditions, and in all settings. The ICF model includes positive and negative environmental and personal factors. And lastly, the ICF model is used to gather all essential information about your patient, organize this information, and then can help you create a relevant treatment plan that helps to address biological, psychological, and social factors contributing to functioning. Here are some key definitions about the ICF model that you need to know before you can use it. So one is disability refers to a decreased ability to participate fully in life due to biological, psychological, social, and environmental factors. Functioning, on the other hand, is the ability to participate fully in life due to biological, psychological, social, and environmental factors. So the ICF model focuses on looking at functioning of an individual and all the factors that contribute to it. Let's look at each box of the ICF model. The first box is called the health condition. This includes a disease, disorder, injury, medical condition, or medical diagnosis that the patient has and contributes to their functioning. The next box is problems with body structure and function. Body structure refers to anatomical parts like organs or joints. Body function refers to physiological functions of the body like movement, cognition, and digestion. Problems with body structure and function can be thought of as biological factors from the biopsychosocial model, where the biological factors contribute to the functioning of the individual. The next box is problems with activities and participation. Activities in this context means completing a task, like walking, moving from sitting to standing, and moving your leg, or standing on one leg. Participation refers to participating in situations in life, like walking to the market, walking up and down the stairs in your home, or moving from sit to stand at your couch. Problems with activities and participation refers to problems that a person has in performing their activities of daily life and participating in their life and in the meaningful things that they have in their life. The last box is called personal and environmental factors. The environmental factors can be considered the social factors of the biopsychosocial model. Environmental factors can include the physical, cultural, and social environment that the person lives in, and includes both positive and negative factors that may be contributing to their functioning. The personal factors can be thought of as psychological factors from the biopsychosocial model. Personal factors include the personality and the personal characteristics of the person, as well as their thoughts, beliefs, and perceptions. And again, these can be both positive and negative and contribute to the person's functioning. Let's look at an example of a completed ICF model so that you can better understand how to use it. The patient is a 17-year-old girl that fractured her right radius bone from a fall from her bicycle. The physician has removed the cast and the fracture is healed. You organize the information you gathered during the assessment with this patient into the ICF model. Let's look at each box. So first, the health condition. For her, the health condition is fracture of right radius bone and the fracture is healed, as well as she reports pain. The next box, which is problems with body structure and function. On your assessment, you note that the patient has decreased pronation and supination range of motion on the right. She has decreased grip strength on her right and decreased wrist flexion and extension active range of motion on her right. For the next box, problems with activities and participation. The patient told you that she is unable to write, type on a computer, or text on her mobile phone. She is unable to complete her school assignments, and she's unable to use her right arm when dressing and bathing. But she is dressing and bathing independently, but primarily using her left arm. Then the personal and environmental factors. So positive things contributing to her function and her condition is that her mother is able to help her at home, her family is educated, and has money and time to participate in physiotherapy. Some negative personal and environmental factors include that she is in 12th grade and she has a lot of pressure to perform well in school right now. She's also afraid to move her arm because of the pain, and she tells you that she's feeling very isolated from her friends and feels sad and anxious about her current situation. Hopefully you can see here how the ICF model can help you organize the information that you take in the assessment to identify the biological, psychological, and social factors contributing to a person's condition, and more importantly, to their ability to function in their daily life. In summary, the ICF model is a tool based on the biopsychosocial model. It will help you gather and use all of the information that you need to treat a patient. We will continue to use the ICF model throughout Beyond Pain. We learned in part 1 of Beyond Pain about neuroplasticity and how when we learn something new, changes are made in our brain and nervous system. We also learned that these changes become stronger if we use the information more often. So you need to use this new information that you learned in part 1 of Beyond Pain and practice the new skills that you learned during this time so that your neural pathways can become stronger. So we will have homework here at the end of part 1. The homework will help you apply the information you learned so you can work with patients. If you do the homework, you'll get much more benefit from this Beyond Pain curriculum. The homework for part 1 of Beyond Pain is to complete the ICF model with at least 3 of your patients. Make sure to write down the information in all areas. Make sure you consider biological, psychological, and social factors that are contributing to the functioning of your patient. If you don't have information that you want from your patient in some of the areas, then ask your patient for that and start to fill in and collect that information. This will help you deliver more effective treatment. Thank you for participating in part 1 of Beyond Pain. We hope that you have new information to apply when working with patients with pain. We look forward for your participation in part 2 of Beyond Pain. Please contact us if you would like any further support or learning opportunities regarding the Beyond Pain curriculum. Thank you.